Okay, we're back again. A very warm good evening, one and all. Apologies for the technical delay. The uncertain weather in Bangalore caught us surprised. Apologies once again. Going back to the program for which we've all gathered here today, we all hope and pray that all of you are doing well and safe. These are certainly very challenging times. Before we start the session, we request all of you all to bow our heads in silence for 1 minute in honor of all those who have left us during this ongoing pandemic, be it doctors, police force, and all frontline workers. We also pray for the others who continue to work on the front line with more strength to help us win the situation, and we hope that this country's zeal and spirit will set India on the path of recovery very soon. We shall bow our head in silence for 1 minute. On this hopeful note, on behalf of PlasmaGen BioSciences, I once again warmly welcome you all. PlasmaGen BioSciences is a proud Indian biopharmaceutical company that has been growing in the plasma protein therapy arena since its inception in 2010. We as an organization are actively working towards bridging the demand and supply of plasma protein therapy products and coincidentally also bridging the awareness gaps for such rare disorders such as PID with eminent doctors like Dr. Sagar Bhattad and Dr. Stalin Ramprakash, and at the same time connecting you all with noteworthy patient advocates like Ruby Chawla and Ruxana Hanif, who have so caringly and patiently put together the entire program. I say patiently with personal experience as these dignitaries have been so very accommodative of all the requests the team and I have made in the last few days. Lastly, we are all sure that at the end of this brief session, which will be presented by this fabulous four with their collective so many years of PID experience, there will be a lot of takeaways for each one of us. Without much ado, I move on to doing the honors of introducing these doctors to all of you all in order of the talk with you. We now welcome our first presenter for the evening, Dr. Sagar Bhattad. He's completed his MBBS, MD, DM, Pediatric Clinical Immunology and Rheumatology. He's currently a consultant pediatric immunologist and rheumatologist at Aster CMI Bangalore. He's also the director of the FPID Center of Excellence for Diagnosis and Management of Primary Immunodeficiency Disorders at the Aster CMI Hospital. He's also the treasurer of the ISPID, the Indian Society for Primary Immunodeficiency, and also the secretary and founder member of Indian Society of Kawasaki Disease. He is the first DM in the field of pediatric immunology and rheumatology in India. He has authored the book Primary Immunodeficiencies Made Simple. He has been trained at the prestigious Institute of PGMR Chandigarh, and he has been awarded the Silver Medal for MD Pediatrics. He's also won the Major General Amir Chand Gold Medal for research in pediatric lupus. He also has vast experience in the management of various types of primary immunodeficiency diseases and complex rheumatological illnesses, including Kawasaki, lupus, juvenile dermatomyositis, and many more. He has received extensive training in laboratory immunology, and he has more than 35 publications in national and international journals to his credit. I now move on to introduce the next speaker for the evening, Dr. Stalin Ramprakash. He's completed his MBBS MD Pediatrics, MRC PSCH CCT Pediatrics at the UK FRC PCH. He's currently a consultant pediatric hematology, oncology, and bone marrow transplant specialist at the Aster CMI Bangalore. He has 21 years post MD experience and more than 15 years of pediatric hemonic experience. He has been trained at the Institute of Child Health and Hospital for Children, Madras Medical College, Chennai, and has received his pediatric training rotation in London, United Kingdom. He also has been trained in pediatric hematology oncology from prestigious UK institutions such as Great Ormond Street Hospital, Royal Marsden Hospital, London, and Royal London Hospital. He has worked as a consultant pediatrician with hematology oncology interest in the UK for 5 years. He has experience in the management of various types of benign and malignant pediatric hematological and oncological conditions and bone marrow transplants, such as thalassemia, sickle cell, ITP, leukemias, and etc. He has various publications to his credit in international journals and has made many presentations at national and international conferences. He has performed more than 250 bone marrow transplants so far after returning back from the UK. Now, I would like to talk about the two societies that we've had the honor of partnering with. The IPSPI, when we talk about the PID community in India, the first and foremost name which comes to one mind is that of IPSPI. The Indian Patient Society for Primary Deficiency is the national organization for PID disorders, which was founded back in 2004. Their efforts and role have been pivotal to the current date position of our nation's PID community. IPSPI has been fighting for the cause since the time of negligible awareness of PID in the nation and were the ones who did the inception of the nationwide PID community under one roof. As a result of their efforts and awareness campaigns alongside strong doctors and medical advisors, India was able to see their first generation of PID patients crossing 16 years of age. Also, as a result of the continued efforts over 2 decades with central and state governments of India, PID has been included in the rare diseases at center. Our nation now has a national policy for treatment of rare diseases. Some of the state governments have also started covering treatment for PID patients. In spite of all the hardships, IPSPI continues to strive forward to accomplish its goals. Our next society, PIDPWS, is an NGO supporting children patients who are born without immunity and who are more susceptible to continuous serious infections. They are based out of Bangalore. They too, in spite of the hardships, PIDPWS continues to strive forward to accomplish its goals. I now welcome Dr. Sagar Bhattad to take over, please.
Yeah, thank you, Shivantika. And at the outset, good evening, one and all. Let me thank PlasmaGen BioSciences for providing us this platform so that we can address the August gathering on this Primary Immune Deficiency Week. Let me start sharing my screen. I hope I'm audible and the screen is visible.
Yes, sir, we can hear you and see the slides.
Yeah, thank you. So, as rightly said by Ms. Shivantika, these are tough times that we are facing these days, and I'm sure the Almighty shall provide all of us the strength to come out of these tough times. Today we have gathered to talk about primary immune deficiency and create awareness, and I'll briefly in the next 20 to 25 minutes tell you why we are choosing this day to talk on awareness regarding primary immune deficiencies. And this is because as per the Immune Deficiency Foundation, the World PI Week, the Primary Immune Deficiency Week, is celebrated between April 22 to 29. That is the last week of April. We observe the World PI Week, and the whole purpose is to increase awareness amongst the community and the physicians regarding these diseases. So, what are primary immune deficiencies? This is not a single disease. They are a group of genetic defects characterized by abnormalities of one or more components of the immune system. So, that means the immune system, which is supposed to fight infection, there is some defect there. And since it is genetic, these defects are present right from birth. And these children, these patients are unable to fight infections just like normal people. So if you look at the recent classification of the primary immune deficiencies, we now call them the inborn errors of immunity. And the latest classification, which was given in 2019, provided us with a list of 430 diseases. And just for your information, 60 plus new diseases were added only during the last 2 years. And if somebody is reading the book on primary immune deficiency, the book initially may look so small, and over the years, it has become a humongous book. This is because rapid advancement in molecular science has now given us opportunity to diagnose many new conditions. So what is the importance? The importance is that one has to be updated regarding this information. What was a disease which could not be diagnosed 10 years back, today we will be in position to diagnose them. And the good thing is that all such genetic testing facilities are now readily available in our country. To make it simple, I would say that we should compare immune system to the army of a body. And as army protects us from our enemies, the immune system of our body protects us from the enemies of our body. Our enemies may be considered as the bad bacteria, virus, and fungi, which our body is facing day in, day out, and the white cells in our body constantly strive to protect us against them. We all know today we are fighting against a deadly virus, that is the COVID virus, and you would appreciate that a small percentage of people are becoming unwell, and I'm sure a proportion of them may have some immune defect which is causing them to land up in more severity. So the white blood cells are the army men which fight our enemies, and they also produce some bullets in our body known as immunoglobulins. And it is these bullets which, when fired by the white cells, kill the pathogens, kill the bacteria, and protect us. So, what we need to understand is that if a child comes to us and is been repeatedly unwell, seeking medical consultations again and again, your child may be suffering from a primary immune deficiency. The word primary here means genetic defect. Immune deficiency speaks for itself. And as you can see, these children often come to us with recurrent chest infections. They have been hospitalized multiple times, receiving antibiotics for pneumonia. They may have repeated episodes of diarrhea or loose motions, sometimes very unusual skin rashes that do not respond to treatment. And sometimes we do see very grotesque looking ulcers, as you can see in this young baby here. And these are all children who have immune deficiencies. And such children go from hospital to hospital for several months. So what is known about primary immune deficiency is that children spend more time in the hospitals than at home, which is an unfortunate thing. And because these are genetic defects, families have often lost many children before the index case is diagnosed. And that is why there is an urgent need to increase the awareness about these diseases in the community. What are the major challenges in India regarding these diseases? There is lack of awareness not only among general population but physicians. Many physicians believe that these diseases do not exist. Lack of appropriate diagnostic facilities, cost constraints, and definitely there are only a few centers which are specialized to diagnose and treat these conditions. So the very first DM training program, which was focused on primary immune deficiencies, was started only in 2014. That was a DM course in pediatric immunology in PGI Chandigarh. And you can see this course is only 7-year-old course, and you will not have many specialists in the country to deal with these conditions. I was fortunate enough to be trained at PGI Chandigarh in 2014. And when recognizing the need for more doctors, for more specialists in this field, we have now launched the FPID Aster Fellowship in Pediatric Immunology and Bone Marrow Transplant at Aster. And we are happy to share that it is this month of April 2021, the first candidate has joined. And this 2 year course would train pediatricians to be pediatric immunologists and transplant experts so that they can go to several parts of our country and cater to the needs of children and adults with primary immune deficiency. When it comes to immune deficiency, I would definitely talk about Jeffrey Modell Foundation, which was set up in US by Fred and Vicky Modell. As you can see in the picture here, Jeffrey, a boy who was born somewhere in 1980s, and this family was extremely happy to say that they had a child who was doing fine for the first few months of his life. Unfortunately, he started getting unwell, had developed recurrent infections, and finally was diagnosed to have an immune deficiency. He did not have antibodies and he was started on treatment. But because of the delay in diagnosis, he lost his life at the tender age of 16. In his memory, the parents set up Jeffrey Modell Foundation, and I must say they have done a phenomenal work across the globe to increase awareness, to fund research in the field of primary immune deficiency. In fact, the JMF Foundation recognizes several centers as centers of excellence across the globe, and Aster CMI Hospital is one of those centers in India. As per the foundation, when should you suspect primary immune deficiency? So some of the warning signs which can actually help all the public who is watching this today is that if a child has got recurrent ear infections, repeated ear infections needing antibiotics, repeated sinus infections, or if a child is brought to us with repeated episodes of chest infections or pneumonia, all these are warning signs to suspect primary immune deficiency. If a child is not thriving well, we all know children should grow. If a child is not gaining weight and height as per his potential, one should suspect a primary immune deficiency. If there are deep-seated abscesses, like if you have heard a child who has developed infection in the liver abscess, must be investigated. In the same way, persistent oral candidiasis, oral thrush, that is an unusual infection in childhood, if somebody has it again and again, must be investigated. In the same way, a family history. What do you mean by a family history? If in a given family, the previous child has had recurrent infections, or unfortunately the family has lost a child previously and the current child is not doing fine, you should try to link it. Why should one family have multiple members who are suffering? Might be this is a genetic disease, it's a primary immune deficiency. So if one starts applying this common sense and starts utilizing these warning signs, we can all pick up these children early and treat them. Look at this global study published by the Jeffrey Modell Foundation way back in 2011, where they surveyed almost and the globe and found out more than 60,000 patients across the globe. What was interesting to note that out of these 60,000 patients, 60% of those patients were adults. So many people have this misconception that primary immune deficiencies affect only children. Let me tell you, majority of these defects affect adults. And as awareness has gone up in the West, a large number of adults are getting diagnosed, whereas in India, it is only a handful of number who have been diagnosed so far. And that is because of lack of awareness in adult physicians, pulmonologists, and gastroenterologists. The Jeffrey Modell Foundation states 1 in 1,200 children suffer from a primary immune deficiency. If you look at the population of our city in Bangalore, it's about 12 million, and I must say there must be more than 5,000 children with primary immune deficiency. And this is what we tried to highlight in a newspaper article way back in 2017. Now, what I mean to say is that they are by no means rare diseases. Individually, they may be rare, but as a group, they are very, very common. But the problem is, I see only what mind is prepared to comprehend. I see only what mind is prepared or what we have been trained. And that means unless physicians are trained to recognize these conditions, we are going to miss these conditions. So what did we do in the last 3 to 4 years was we wanted basically to increase awareness amongst the medical community, because that is the first target, that medical community must become aware. And we started talking about these conditions at several CMEs, almost as a hospital initiative. We did 40 CMEs in the last 3 years, spoke on several conferences, you can say national conferences, trade conferences, infectious diseases conferences, fever conferences on these conditions. And it is this way we were able to touch upon several thousand doctors and tell them what is primary immune deficiency. We also try to create a brief videos, just 3 to 4 minute videos on YouTube highlighting what is primary immune deficiency. And again, these brief videos have reached several specialists, several clinicians, and they have been more comfortable in diagnosing these conditions now. Newspaper articles were published several times highlighting how common these conditions are and how we can all diagnose them. We also have had the opportunity to go out and talk to press about these conditions, and the patient organizations have been extremely supportive in bringing out this awareness. And finally, I thought that there was a need to have a very small book on primary immune deficiency. The reason I'm telling this is because we have large textbooks which run more than 1,000 pages on immune deficiencies, but then physicians often find it difficult to read such large volumes. So I thought, let's have a small handbook, which is just less than 200 pages, which physicians can quickly refer to and make a diagnosis of primary immune deficiency. And this book now is readily available, and several hundreds of pediatricians have had this book and said that it has been making a difference to their practice. The result of all this has been that over the last 4 years at Aster, we have diagnosed more than 180 cases with primary immune deficiencies. And you can see this is not a single disease. There is a variety of conditions that we have been able to diagnose. And I could say that at least 3 to 4 new children are diagnosed with primary immune deficiency every month at our hospital. So these diseases are not, by no means rare diseases. But why is the diagnosis so crucial? Because these children often keep falling ill and moving from one physician to another physician unless you make a diagnosis. So once you make a diagnosis, they stop moving from one hospital to another. We can start appropriate therapy. We can provide with a genetic counseling wherein you can definitely prevent the next child from having this condition again. Talking broadly, the broad categories of primary immune deficiencies could be a group wherein you don't have those bullets called immunoglobulins. For example, X-linked gammaglobulinemia. I'm sure some of the parents of children with primary immune deficiency who are watching this program would realize their children have X-linked gammaglobulinemia and they have been asked to take immunoglobulin infusions every month. And then there is another group of diseases where you don't have those T cells, which are very important fighters in our body, and you get very serious condition called severe combined immune deficiency. Now, this is a serious condition. Children often don't survive beyond the age of 2, but now we have the wherewithal to do bone marrow transplants in this condition, and many of our children are now doing fine. And another group of fighters in our body are neutrophils, and if you have a problem there, you can develop a condition called chronic granulomatosis. These are 400 plus conditions. What I'm trying to highlight is only the prototype conditions among them. The treatment, if you don't have immunoglobulins, the first category needs intravenous immunoglobulin infusion. And today in India, we are fortunate to have companies like PlasmaGen and many other companies which provide IVIG, and we are able to infuse immunoglobulin injections to most of our patients. The other group of disorders like SCID and CGDs need bone marrow transplant. Now, IVIG, the dose is 400 mg per kg per month. So imagine you have a 20 kg child, a 6-year-old child who needs 10 grams of IVIG, and the cost can be quite phenomenal, up to 16,000 per month. And this needs to be taken practically every month for life. So this is a significant financial burden to many families. So looking at this, what we did way back in 2017 is we approached the Canadian International School and asked them to ask their children of around 6th to 7th grade students to run a program to raise funds. And the children came up further, raised a few lakhs of money, and we were able to give free IVIG to almost 15 children for a year. So initiatives like this can help these patients. Then there is a book written by Dr. Chetan Ginigiri, one of my colleagues at Aster, who is passionate about child safety. And this book, Playful, which is on child safety, was then sold by many children here. As you can see, Mr. Srinivas Lingam in this picture, who has been a constant donor and a big support for many of our children. With his support, kids went out and spoke about child safety and sold these books, and all the proceeds of this book were then used for treatment of primary immune deficiency children. As you know, in Bangalore, we have the Primary Immunodeficiency Patient Welfare Society, and this society also has been striving hard, and with their efforts, they were able to they were able to get the state government provide free immunoglobulin infusions, and several patients have been taking free IVIG infusions for the last 2 years. Of late, there has been a break. I'm sure this is a temporary break, and the government will take up this again, and these children must get free IVIG infusions. Because regular IVIG is a must, half-life of IgG is only 21 days, and that is why this infusion must be repeated every 3 to 4 weeks. If you don't give regular therapy, these children develop irreversible lung damage, and that is why regular IVIG is a must. Now, when it comes to bone marrow transplants, yes, to perform a bone marrow transplant, we need that these patients undergo a timely diagnosis. We need the expertise and the finances to transplant these patients. As far as the expertise is concerned, at least there are several centers in the country now which are doing the transplants in primary immune deficiency. However, expertise in PID transplants is available only with a few. We are fortunate here to have Dr. Fulvio Porta's support, who is an Italian expert who has performed more than 700 transplants to date. We have Dr. Stalin Ramprakash and Dr. Ragram, who have performed several transplants in primary immune deficiencies over the last few years. And with their support, we are able to perform transplants in primary immune deficiencies. Now, when it comes to finances, transplants do ask for a lot of finances. So we have the AstraZeneca Foundation, which provides part support. We have several philanthropists who support individual patients. Then there are crowdfunding platforms where individual donors come up and support our patients. And then we regularly approach the CM and PM funds. And through this network, we have been able to transplant several of our patients in the last few years. And these are few quick pictures to showcase a child with severe combined immune deficiency, a child with leukocyte adhesion deficiency who underwent bone marrow transplant. And then there are another child who was quite unwell for 2 months and then got bone marrow transplant and is doing fine. So you can see treatment is available to these patients today. Talking about patient organizations play a very phenomenal role in not only spreading awareness, but funding research and then advocating law changes for these patients. Now, if you look at an international organization like the IPOPI, the International Patient Organization for Primary Immune Deficiencies, they do a lot of work. But what is important, look at their income. They say in income in 2017 and their website was almost 12,40,000 pounds. And how do they raise funds? Not only through Congress venues, to volunteer work, donations, corporate donations. And it is these funding that is utilized not only for patient treatment, but most important of all, for funding research so that future patients are diagnosed early and treated in time. I'm sure this is what we look forward to in future with the organizations in India. They should come up and they should be raising funds, because when parent organizations go and propose what are the challenges, the society will be more accepting that this is a problem and they shall make a big difference. Look at this. This is a congress organized by the Patient Welfare Society, IPIC 2019 in Madrid. And this was organized by IPOPI. I'm sure organizations in India in future would be organizing such meetings to spread awareness. And in India, we are fortunate enough to have not one but two patient welfare societies, like the Primary Immune Deficiency Patient Welfare Society in Bangalore, the Indian Patient Society for Primary Immune Deficiency, which is based out of North India. I'm sure both these societies have been doing a lot of work in the last few years, but then it is time for them to step up further and take this to the next level. Now, whenever we talk about give any talks today, the talk cannot be completed without having a brief talk on COVID, because it is everywhere today. And I'm sure patients with primary immune deficiencies do have a lot of questions when it comes to COVID, because they are immunodeficient and naturally they are worried whether they will catch up with the COVID and get serious infections. So what has the literature been talking about COVID and PID? We don't have much literature from India. However, if you look at this publication from the West, it clearly states that in this pandemic, that patients with primary immune deficiencies are tenfold at higher risk of having mortality compared to the general population. That means definitely certain group of patients, especially those with primary combined immune deficiencies, are at much higher risk of mortality. And that is why it is very essential to protect these patients from COVID. This is another paper which was published, which showed that at least 30% of patients with primary immune deficiencies have a mild disease. So it is not necessary that all patients will develop severe disease. A proportion of them may develop severe disease. Now, the next question is quite natural, whether the patients should take vaccines. And, and the government has announced that from the next month onwards, practically all adults are going to get these vaccines. So should patients with primary immune deficiency take these vaccines? Now, what does the Immune Deficiency Foundation say? They say that we know that the patients with primary immune deficiency may not respond as good as to these vaccines as compared to the general population. They may not make good amount of antibodies, but then they may still produce good cellular immune response, especially those who have antibody deficiency. So the general recommendation is please give these vaccines. So whenever you get a chance to get vaccinated, please go ahead and get vaccinated. It may provide little benefit to complete benefit, but then there is no harm done. Whenever I talk on immune deficiencies, it is often that I present this slide and we state that when you hear of hoofbeats, just don't think about horses, think zebras. Think zebra is the logo of the Immune Deficiency Foundation. What do we mean? It is especially talking to doctors, we always train to talk about common diseases, the horses, but then the zebras do exist. So it is my sincere appeal to physicians and pediatricians to think about zebras whenever they deal with patients who come with unusual presentations. Pink Zebra is the logo given by Immune Deficiency Foundation, which was founded by Marcia Boyle, again the mother of a child who had a primary immune deficiency. In the picture, you do see Professor Surjit Singh from PGI Chandigarh. I have been very fortunate to be mentored by this great personality in PGI Chandigarh, and I'm sure many of you know him. It is because of his vision that the DM program was started, and several doctors are now getting trained for treating primary immune deficiency. Having trained there, I am now working at Aster CMI Hospital, and I'm very happy to state that we have one of the largest pediatric departments in the city of Bangalore, not only catering to immune deficiency, but pretty much any problem with a child, A to Z, for treatment of children. And equally happy to share that the FPID, the Foundation for Primary Immune Deficiency, which is based out of US, has recognized us as one of the centers of excellence for diagnosis and treatment of primary immune deficiency. And to end, I would say primary immune deficiencies are everywhere. Look for them, they are always around. Although some progress has been made in the last few years, more and more patients are getting diagnosed, more and more patients are getting treated. We still have a long, arduous journey. A lot of these patients are still undiagnosed, and we need to diagnose them and treat them. Thank you once again. Thank you, PlasmaGen, for giving us this opportunity. This is my email ID and a number, and if there are any questions, I would be happy to take up. Thank you.
Thank you, Dr. Sagar, once again for very passionately delivering this talk on what is PID, its awareness, improved outcomes and treatment options, and even addressing most of our curious minds on how COVID is impacting PID and its patients. We now invite Dr. Stalin to explain to us how BMT is a treatment option for PID. Over to you, sir. Dr. Stalin, please unmute yourself. Dr. Stalin, you'll have to unmute yourself, sir.
You're able to hear me?
Yes, sir, clearly. Thank you.
Yeah. Good evening, everyone. Thank you very much for PlasmaGen for giving this opportunity. Like Dr. Sagar said, this is challenging times for everybody. I hope that the corona problems will get better soon so that we are able to do our normal day-to-day activities. And even normal people are suffering, people who are already existing problems, whether it is cancers or primary immunodeficiencies, their normal care is now getting quite affected because of the corona. So with that, I will start my presentation. So BMT is a treatment option in primary immunodeficiencies. So a lot of the people generally, when we talk about BMT, the awareness as such is not quite high. So I'm just trying to sort of give an overview of what is BMT involves and how it can help the primary immunodeficiency patients. So immune system as such is quite complex. Like Dr. Sagar said, it is like an army, and the army has got several wings. Different parts of the army does different job. They all together try to fight the infection. And so your patients with immunodeficiencies, usually it is not the whole army which is deficient, is it one bit of the army which is not working. And so whenever we talk about primary immunodeficiencies, we talk about genes, because most of these primary immunodeficiencies because of some genetic defect somewhere which is controlling the immune system. So what is basically genes? Because a lot of the audience here, some of them may not have a medical background. So I will try to simplify it, and I will give some analogies to explain this. For example, so in the past, before the time of internet, if you want to learn about anything, then you have to go and open the encyclopedia. These encyclopedias are large volumes of books, several volumes, which will give a lot of information about anything you want. And so we can think that these genes, what we talk about, are packaged, or the information which are packaged in chromosomes. So each chromosome can be considered as a volume, and each chapter is a gene. What is interesting is the entire book is written with 3-letter words. So the 3-letter words are the codes basically, and these are which are the building blocks for making different proteins. So it is almost, if you take the whole genome, so the entire genetic code in a human being, it is almost made up of like 3 billion base pairs, which is 1 billion words are there in this book. And even more interestingly, the books are divided in pairs. So there are 23 pairs of these chromosomes, and half of it comes from the mother and half comes from the father. For each job that is to be done, there is 2 sets of instructions. One comes from the father and one comes from the mother. And these genes are in the center of the cells called nucleus. So this is the center of the cell. So all the human tissues are made up of cells. And you have got different specialized cells. For example, liver has got liver cells, and blood has got blood cells, and so on and so forth. And these genes are made up of what we call as a double-stranded DNA. And there are these what we call as a nitrogen base pairs. The sequence of these pairs is what sort of is the code. So interestingly, there are about 15 trillion cells in the human body. And every single cell from an individual will carry the same gene, same genetic code, which means right from the stage of one cell to the adult human being, every cell has got the same set of instructions. Some of them are switched off in different cells, but every time when the one cell becomes 2 cell, the instruction has to be copied without a mistake. Sometimes, even though this phenomenon is quite well orchestrated so that the mistake doesn't happen, sometimes mistakes do happen. But what will happen is once the mistake happens, this mistake is going to be carried forward for all the following cells to come. And that's where the problem lies. So these genetic codes, you can sort of make it look like some kind of cooking instructions. Say when you have a cooking recipe, it gives an order. Okay, first add this, next add this much of this, that much of that, and then finally you get the dish. The genetic code exactly does that. Each 3-letter code codes for an amino acid, which is the next amino acid is the next 3 letters. So as per the code, the proteins are made. If there is a mistake in the code, the protein may change. Sometimes the mistake will change the protein, sometimes it doesn't change the structure of the protein. So that is where the mutation comes. So basically, when we talk about genetic mutations, the mutations are mistake in the codes which make the protein. And if the child is born, say for example, father or mother has one mistake and it has gone to the child, some diseases can be expressed even if there is one mistake. Some disease there may be two mistakes are needed. And once the child is born with that mistake, every single cell in the body is going to carry the same mistake. The immune system as such is very complex. You can see all the different colors and different things and different sort of letters written next to it. These are all different chemicals which control the immune system, and the different cells which are made, different signals which will make them proliferate, will go down. So all of these are controlled by genes. If there is a mistake in any of these things which control the development of the immune system or maintenance of the immune system, then they are going to malfunction. And that is exactly what happens in the primary immunodeficiencies. So Dr. Sagar told about the classification of the immune system. I mean, this is not meant to be read. I just wanted to show is to say how elaborate and how difficult they are. So the classification keeps going, different parts of the immune system. And so you need some really specialist people in order to exactly find out what exactly is the diagnosis. And then because the treatment which follows is all based on the diagnosis. So the immunologist like Dr. Sagar, who works through these various investigations and finally fits the patient into one particular diagnosis. And then the treatment, what is the treatment that has to be given is based on the diagnosis. There are some defects, like Dr. Sagar mentioned, A-gamma globulinemia, where the immunoglobulins are not made by the body because there is a defect in the cells to make the cells which make the immunoglobulin, or the immunoglobulin cannot be made because of a genetic mutation. But the only defect is that immunoglobulins are missing, so which can be given from outside. So those patients need lifelong immunoglobulin treatment. So those patients don't need a bone marrow transplant. Whereas there are other situations where either the particular cell, for example, T cell, which is central part of the immune system, is not being made, or the neutrophils are not able to make a chemical which will kill the bacteria. So if there is a fundamental defect in the cell and that cannot be corrected by giving medicines or proteins or anything externally, those kind of, and if the disease is severe enough, then they will need bone marrow transplant. Because bone marrow transplant is a procedure by which you are correcting the immune defect. You are giving healthy cells which will maintain themselves so that the immunodeficiency which the patient gets is corrected. And a lot of the people think when the term bone marrow transplant is mentioned, people assume it is like a surgery, because you talk about liver transplant, kidney transplant, and then sort of bone marrow transplant. Fortunately, bone marrow transplant is not a surgery. We are actually transplanting the cells from the patient, donor to the patient. We are transplanting healthy cells. So we don't need a surgery to put the cells back in. The cells go in as if you are giving a blood transfusion. And it is usually a permanent cure. When the bone marrow transplant works, you have permanently cured because the cells which make all the other cells have been changed to a normal cell, which doesn't have to carry the genetic defect anymore. So all the following cells which are going to come from the stem cells from the donor, they don't have the same defect anymore. So the defect gets corrected. So like I mentioned already, not all the primary immunodeficiencies need transplant, but a significant proportion of them do, and most of those patients who need bone marrow transplant are usually a very serious conditions. They don't live for very long, or even if they live, they have multiple infections over a period of time, and the quality of life is extremely poor. So there are different terminologies which are used for bone marrow transplant. People talk about stem cell transplant, hematopoietic stem cell transplant, allogenic transplant. They all mean the same thing. And depending on where the cells are taken, where the stem cells are taken, they are called as matched related transplant, or matched sibling transplant, matched unrelated transplant, haploidentical transplant where you are doing a half-match transplant from the father or mother, or if it is the cells are collected from the umbilical cord blood, then they are called as umbilical cord blood transplant. In all these things, we always look for who is the best donor, because the brothers and sisters can be 100% match with each other, and they also carry other genes, they will share half of it. So the number of complications and the success rate, everything is far better, and the amount of treatment needed before the transplant, they are all far better if there is a matched brother or sister. And if that option is not available, either they don't have brothers or sisters, or they have brothers or sisters who is not a match, then we will go for a matched unrelated donor. So there is unrelated registries in our country and across the world where willing donors who have registered themselves as willing to donate stem cells. And so they have been typed, and we can quickly find out whether there is a unrelated match available in the registry or not. So if such situation is available, then we can request those stem cells, and then we can proceed with the transplant. Even if that is not available, then we go for something called as a haploidentical transplant. About sort of 15 years ago, haploidentical transplant was not possible, or the results were so extraordinarily poor that was considered purely experimental. Whereas now the technology has improved so much, we are able to do half match transplant either from the father or mother for many conditions, including primary immunodeficiencies. I must say, in our Astra CMI hospital, almost 70 to 80% of the transplants are haploidentical transplants, because a lot of the time you don't get the matched related or unrelated donors. And how is it different from the other organ transplants, for example, kidney transplant or liver transplant? One, we have already mentioned that it's not a surgical procedure. And another very important factor, because whenever we talk about transplant, especially if mother or father is a donor or a sibling is a donor, the first question the family asks is the donor going to be okay? Because of course we all know that the recipient has got a serious problem, medical problem, but the donor is healthy. So everybody wanted to make sure the donor will not undergo any problem and they will not have any consequences. I can reassure all the parents and others who are here, bone marrow donation is almost a very harmless procedure. The risks are too low. They may have to undergo one small anesthesia to collect the stem cells, or they may have to put a central line in. But compared to any other organ donation, so if you are donating a kidney or a liver, you actually lose the kidney or you lose a portion of liver, and you have to undergo a major procedure, major surgical procedure. Whereas donating stem cells is almost like donating blood or platelets. The donor does not lose anything. So that is something which is very important to remember. And another important factor is that once a bone marrow transplant is a success, usually by 6 months to 9 months to 1 year, we sort of stop all the medications. They are not on any medications. For example, if somebody on a liver transplant or a kidney transplant, they will have to have lifelong medications. And moreover, say if you do a kidney transplant, you have got a life for that transplanted kidney. So normally it's about, say, let us say 10 years, which means after 10 years, that kidney is going to stop working or going to get into more serious problems. Sometimes you may need another transplant. When a 60-year-old man needs a kidney transplant, okay, another 3 kidneys, they can sort of till the end of their life, it is okay. When a 10-year-old needs a kidney transplant, you can imagine how difficult it is. Whereas in bone marrow transplant, once the transplant is successful and there is no GVHD, it is a permanent cure. Unless somebody asks a few years down the line, unless the family member says my child had a bone marrow transplant, nobody will know about it. The child will look perfectly normal like every other child. And so there may be some long-term implications like infertility and things, but that is, we are weighing against situations where the child may not have survived in the first place. And the quality of life, like I said, they live a life like everybody else. They go to school, college, go to work, and everything. So even the first transplant patients are still living, which was done several years ago before the technology was so well developed. So here we are talking about transplanting the stem cells. So stem cells are like a mother cells, which give rise to various other cells. And one important property of the stem cells is that they can make more and more of themselves. Whereas the older type of cells, they cannot give rise to many different cells. So that is the fundamental property. So when we are trying to do a transplant, we are basically trying to take the stem cells from the donor, they are specialized cells, and put it into the patient and make them work, and ensuring that the stem cells will not be attacked by the recipient. They will survive and will settle down and start growing. So bone marrow transplant is done to remove the diseased marrow or damaged marrow, or if the stem cells are not working for whatever reason. So for example, diseased can be leukemia and other things. The absent stem cells are aplastic anemia, and damaged stem cells are the stem cells which are not working properly, maybe sort of primary immunodeficiencies. So once the transplant process is complete, it's not only the white cells which are sort of the main purpose of doing the transplant in the primary immunodeficiencies, to get normal white cells wherever the part of the white cells which was not working earlier. The red cells, platelets, all the blood cells are going to come from the donor in the future. Say, for example, if you do a bone marrow transplant on a patient who is A positive and donor is O positive, after the transplant is successful, 1 year down the line, the patient is also O positive now. And the immune system, we are giving a completely new immune system from scratch after the stem cell transplant. So the patient who has got an immunodeficiency, it is almost like shutting off the computer and restarting fresh and putting all the new apps back in. So, but this process takes a bit of time. So and the stem cells also can be collected from the bone marrow. It depends on the situation. Sometimes sibling transplant, we may use the bone marrow. Unrelated transplant, or most of the time peripheral blood. And the cord blood transplant is something which we often don't not many transplanters want to do cord blood transplant in India, because of the fact that the time for the new cells to come back and the immune system to come back takes extraordinarily long time with cord blood transplant, with a lot of infection risk high in India because of all the resistant bacteria around. So we almost don't do cord blood transplants nowadays. And like the blood group matching, we need to do something called as HLA matching. So this is a much more complex blood grouping of the cells. So any organ transplantation, we sort of need to do this HLA matching. In a given family, parents are always 50% match. A brother or sister can be either no match or 50% match or 100% match. So the chances of being 100% match is about 1 in 4. So we need to prepare the patient for transplant. So that is for 2 reasons. One is that even though the patient's immune system is defective in case of primary immunodeficiencies, still there are bits of immune system which is active. So they can attack and destroy the cells which we give from the donor. And also we need to create the space for the new stem cells, because if all the donor patient's own stem cells are sitting there in the places where they are supposed to sit, the new cells cannot establish themselves. So we may have to do some preparation for that process, and that's what we call as conditioning. So the procedure of stem cell transplant, so first step is to establish the diagnosis. Then we find out who is going to be the donor. So there is a long discussion with the family regarding what is the condition, what is the likelihood of what is going to happen based on the current medical experience, what can we expect in the long run for this patient without a transplant, and what are the risks of transplant, and then we, as together with the family, we make the decision. So always, whenever in medical decisions, we have to weigh the pros and cons and make the right decision appropriate for the family. So most of the time, we used to say that you are taking some risk now as either a small baby or a few years old child. for during the transplant, but once the transplant is successful, your risk reduces. Whereas if you don't do a transplant, there is ongoing infection, there are problem after problem after problem, and the long life quality is bad, and the patient will eventually succumb to the disease. So it always have to sort of weigh the risks and benefit. So in terms of to simplify transplant, we can almost sort of use the analogy of getting the garden ready. Say, for example, first you need to get the soil ready. So you have to remove the weeds. You have to make all the condition of the soil ready to receive the seeds. So that is what we call as the conditioning phase. Normally, this is about somewhere between 7 days to sort of 12, 14 days based on the condition. Sometimes it is even longer if it is a haploidentical transplant. So in that process, we are just getting the patient ready. Before that, in primary immunodeficiencies, we need to treat any infection as much as possible. Sometimes it is not always possible to clear all the infections, but we have to take the patient into bone marrow transplant or stem cell transplant in as fit state as possible. And then after the conditioning, then basically we give the stem cells, and that is like akin to putting the seeds into the ground, sowing the seeds, and then they try to grow. So that is the time where the initial phase where there is a lot of immune system is not back. Some part of the cells have come back, others have not come back, and there are problems related to the chemotherapy or the other medications which we have given, and then we have to give medications to prevent the cells from the donor from attacking the patient, which we call as GVHD, and slowly the immune system comes back. So usually after like 2 years or so, the immune system is almost equal to that of anybody of their age. So in the long term, they are completely sort of, their immune system has come back to normal. They can do everything that is normal, what everybody else does. So for example, when you buy a car, if the car has got a sort of the fundamental design is wrong and the car is not going to run, you can't do anything. You have to replace the car. If there is a small bits of parts which is not working, then we can replace them, say for like immunoglobulin and things. So when we do a transplant, you are trying to replace the car. But the only difference is the car will come out of the factory only it is fully ready. Whereas when we do a bone marrow transplant, the basic structure of the car is there, but the car has to be fully ready while it is running. So that is where the risks of transplant comes, the risks of infection, the risks of graft versus host disease, the risk of graft failure. But say a condition like severe combined immunodeficiencies, where we do not expect the child to live beyond 2 years of age, there is no other option. Even if the transplant rate success rate is 70 or 80%, that is 80% success rate versus 0% success rate. So there is no question about what is the right decision. So as far as doctors, we are concerned, either myself or Dr. Raghuram, we are the bone marrow transplant consultant, and Dr. Sagar. So we all together, we have to make it clear to the family, what are we expecting from this condition? What is the long-term outcome? And what are the risks of transplant? And then so that they can make a very informed, useful decision. And major complications of transplant, as I have already mentioned, there is a risk to life, which is always there. But with modern techniques and advances in the medicine, that risk is going down all the time. The risks of various infections, the risks of the transplant not working, that is what we call as a graft failure or rejection, or the risk of GVHD, where the donor cells attacking the patient. Most of the time, if it is mild, we can manage it. It's a temporary phenomenon, it will settle, but sometimes it can become severe as well. So what are the factors which we take into consideration? Because some of the families who are listening to this, they may have a child who may or may not need a transplant, or they may not be aware of this option. So we sort of take several factors into consideration before considering somebody for a transplant. One is the diagnosis and what is the likely outcome in the long run without a transplant, and the age of the child. It is always better when the transplant is done as early as possible rather than when you're doing a transplant for an immunodeficiency at the age of 15 or 20 or 25 years, because already a lot of infections and organ damage has happened, whereas an young child, 1 or 2 infections might have happened, but the child is still in a very fit state. So they are more likely to sort of come out of the transplant much better shape. And the severity of the illness, of course, if a mild severe illness, mild severity, then we may not advise transplant. If it is really severe and life-threatening, or the quality of life is extremely poor, then the transplant will be an option. And also the family choices. Ultimately, we as doctors, we are advocates for the child, and our job is to give the information, and make sure the family understands and takes the decision, rather than they are taking an emotional decision whether for or against bone marrow transplant. And financial considerations, that is a big role in our society, because in India, sometimes medically we know what needs to happen, the family knows what needs to happen, but finally the finances where that becomes a problem. The family has got other children, the other families, and they have got so many other things to balance. So in Aster CMI, we started our transplant program by 2017, and we have now transplanted almost more than 50 patients, and of that, some more than 35 patients are primary immunodeficiencies. So with the support of Dr. Fulvia Porta, Dr. Sagar Bhattad, our ICU team, and Dr. Raghuram, so we are able to help a lot of children and many of them are doing well at the moment. And also we try to help the families in many other ways, because we understand the lot of the children, the families are very young. So whenever they present a small child, baby with a severe immunodeficiencies, the family is very young, they are just starting their family, they haven't got a lot of financial resources at their hand. So we try, like Dr. Sagar Bhattad has already highlighted, we sort of use this help from various sources, including the crowdfunding platform, donations, support from the hospital, and many other means, and trying to minimize the cost of transplant as much as possible. So I'm grateful for the entire team which made this possible, and I'm grateful for the opportunity to present today. Thank you very much.
Thank you. Thank you, Dr. Stalin, for broadening our PID awareness towards BMT in its entirety, right from the basics of genetic compositions to treatment as an option with very relatable analogies. Thank you once again, Dr. Stalin.
Thank you.
We now welcome Mrs. Ruby Chawla from the Indian Patient Society for Primary Immunodeficiency, IPSPI, who's joining us all the way from New Delhi. She's a bit unwell, but has still managed to come and join all of us and share with us her views on a PID patient's perspective. This only goes to show her passion to create more awareness on PID among parents, patients, and caregivers. Over to you, ma'am.
Hello. Hello, everyone. Good evening.
We can hear you, ma'am. Good evening.
Yeah, myself, founder and president of Indian Patient Society for Primary Immunodeficiencies. And about IPSPI, like I had given the write-up. Can you just give a little introduction about IPSPI? Or should I start with sharing my screen?
Yes, ma'am, you can do it.
Okay.
Thank you.
Is my screen well visible?
Yes, ma'am, clearly.
And am I audible?
Yes, ma'am, very clearly.
Okay, thank you so much.
Thank you.
Good evening, everyone. Welcome to Indian Patient Society for Primary Immunodeficiencies. Our aims and objectives are to secure early diagnosis and adequate treatment for all those affected with primary immunodeficiencies in accordance with current medical standards. We propagate and run awareness programs and projects for the treatment and education of PIDs amongst doctors, parents, legislators, and government officials. Our alliances are we are the National Member Organization of International Patients Organization for Primary Immunodeficiencies, IPOPI, which is the umbrella organization of the world. International Alliance of Patient Organizations, that's a global voice for patients, and we are the full members of IAPO. We also partner ORDI and IORD, which are the rare diseases organization in India. First, now, as you know that COVID-19 is going on and how we are coping during COVID-19 as one big nation, some points I will like to list in. IPSPI believes in seamless flow of information and equal participation by all its members. Efficient internal communication helps in quick flow of information among the group. It's the pillar of strength. India is a very big country and communication relies more on personal connections and rapport. Continuous discussion giving efficient and smart administration and communication within the group. IPSPI has an active member base. Members understand the importance of internal communication for the success of activities and awareness events of the society. IPSPI celebrates and respects the diversity of our beautiful large country, India. We ensure that the regional sentiments are always given equal weightage as unity is the pillar to an organization's success and longevity. With our seamless flow of information by efficient internal communication using various social platforms, we aim to achieve goals of our society with unity in diversity of India. Some challenges faced by India's PID community during COVID-19 pandemic. Due to the rise in COVID cases throughout nation, the patients are at risk even while stepping out of their house for IVIG treatment. As this is an ongoing treatment and it is from every 3 to 4 weeks they are taking, it's very difficult to maintain the continuity of the treatment. In the difficult times where people are losing their respective jobs and businesses have undergone severe losses, it is becoming extremely difficult for our patient community to cope with the cost of IVIG treatment and medicines. Although through continued efforts of IPSPI and its nationwide patient community, we have been able to get the treatment coverage for PID patients in some of the states via state governments, but the vision of free IVIG treatment in all states of India is yet to be realized. Vaccination drive for COVID-19 remains a challenge for the PID community in the coming days. Some of our recent activities. Asian Advocacy Workshop was held on 17th and 18th of April of 2021, which was organized by our international organization, IPOPI. IPSPI representatives KCLN Rao, Secretary, and Rishi Chawla, Executive Member, participated in the workshop and were highly appreciated. The insightful presentation on internal communication was done by KCLN Rao, Secretary IPSPI, and was applauded. As we are unable to attend any meetings physically in this COVID-19 pandemic, webinars have been held and we have well represented in many webinars. And this is one of the slides showing the certificate which was given by WHO, World Health Organization, which was a webinar series on patient safety during COVID-19 in times of COVID-19 in the Eastern Mediterranean region. And it was a wonderful eye-opening webinar where we got to understood that how they had made the health services available for the COVID-19 patients as well as for the diagnosis and for the treatment too. So the healthcare facility was wonderful in the Eastern Mediterranean region that was shared with them. We happened to attend the webinar series of primary immunodeficiency courses given by PGI Chandigarh, and that was excellent and very knowledgeable, very informative too. We had the Global Rare Disease Conference on International Rare Diseases Day, and this was was wonderfully done, organized, and that helped for the national policy of rare diseases, which has come through. In 2020 February, we had the APSIT conference, Asia Pacific Society for Primary Immunodeficiencies, in Chandigarh, PGI Chandigarh. These are some of the slides showing the photographs. We held a stall over there, and we had the presentation too. Martin Pergent, our chairperson from IPOP, was there in the meet, and it was attended by Nizar also, Dr. Nizar from France. This is also one of the activity that we had done. We had the walk for awareness on PID and supported ORDI event 2 for awareness on rare diseases race for 7. We held the event in collaboration with AMSA India, that is the Asia Medical Students Association. The walk for awareness of PID was done in Jantar Mantar, New Delhi. They were also awarded the certificates and the logo. IPSPI booth was held in International Conference on PID in Hotel Leela, Mumbai, which was held in 2019, March 9 to 11th. These are some of the slides just showing the activity. We keep on doing CMEs, continuing medical education programs for the awareness among the medical fraternity. And these are the slides showing the activity done, CME done in Hindu Rao Hospital, and NDMC Medical College, which was organized by IPSPI and Hindu Rao Hospital, the NDMC Medical College. This is the one of the photograph of IPOP Asia regional meeting which was held in Bangkok. We had the CMEs and workshops on PID in MAMC, Maulana Azad Medical College, LN Hospital in April 2019, marking the World PI Week of 2019. And these are some of the slides showing the group. And here's some doctors who are taking, Dr. Dinesh Kaul from Sir Gangaram Hospital. He had taken the presentation, as well as other doctors and patients. Again, in August 2019, we had CME in LN Hospital, MAMC. First was the workshop, and then we had the CME too in the same hospital for the awareness among the medical students, as well as whole medical fraternity, nurses, as well as doctors. Now coming to cost of IVIG therapy as a proportion of average household income in India. As you know very well that as the age increases, the dosage of the IVIG treatment also increases, intake also increases. And for most of the common forms of PID, IVIG has to be taken regularly, and it is the most common form of treatment. So for 1 year child, you may say that he needs 5 grams, he or she needs 5 grams, which is 25% of the cost of IVIG as proportion of average household income. And as the child grows, he's 5 years old, it increases to 10 grams, and it becomes 50% cost as proportion of average household income. Then just the double, 10 years, for 10 years another 5 grams, so it is 15 grams, which becomes 75%. And for 15 years, 20 to 25 grams likewise, and 20 years, 25 to 30 grams, which is 125 to 150%. And this becomes very difficult if you say for out of pocket expenses. Rare diseases like PIDs are an important public health issue and a challenge to medical care. While some PIDs are very rare, for example, SCID, severe combined immune deficiency, others are more common, for example, selective IgA deficiency. Together, diagnosed PIDs may affect around 1% in 1200. It is estimated that 10 million people suffer with PID worldwide. And based on that, more than 1 million in India are estimated to suffer from PID. Currently, more than 1,000 PID patients nationwide have been diagnosed. The most common forms of PID patients diagnosed suffer from hypogammaglobulinemia, CVID, common variable immune deficiency, X-Leigh-Bruton's disease, or X-linked gammaglobulinemia as you call, and CGD, chronic granulomatous disease. Coming to the achievements of IPSPI, our great efforts and lobbying for more than a decade with central and state governments of India has resulted in inclusion of PID in government agenda. PID treatment is provided by government under national health schemes in some states of India. We reiterate that IPSPI has been struggling from last 15 years for the survival of PID patients. For the first time in Indian history, our children diagnosed in time and taking regular treatment are now adults and leading social, productive, rewarding lives. A humble appeal to all, please find the video in next slide on a burning topic as of now.
Ma'am, we cannot hear the audio.
Uh, Hello? Yeah.
Yes, ma'am, we can't hear the audio from the video.
Oh, video also?
Yes, ma'am. We can hear you, ma'am, but not the video.
Video name. And just a minute, I'll just check. No video and audio. Just a minute, I'm checking.
Yes, ma'am.
Is it, can
We still
you,
can't. We still can't hear.
no. Okay. Okay. Okay, I think there is some little difficulty in sharing this. Um, Actually, these were some of the videos for the stressing upon the plasma collection, because IVIG is the mainstay of the treatment for most common forms of PID, and as IVIG is plasma derivative, so we had some videos from our patients showing stressing upon the donation of plasma. Just a second, I'm trying again if I can do that, share that.
Sure, ma'am. Ma'am, you can
Can
unshare
you,
the screen and share the screen by clicking joining with audio.
I can, okay, just a second. Should I unshare my screen?
Yes, ma'am. Yeah, you can unshare the screen and then share it again by clicking joining with audio.
Okay, okay. Unshare the screen and then share the screen by clicking on joining the audio. Unshare the screen. And then again share the screen. By clicking on joining the audio. I'm unable to do that.
Ma'am, when you click on the share tray, it says include computer sound as well on the top left-hand corner. Include computer sound.
Include computer sound.
Yes, ma'am. When you click on the share tray.
Include computer sound. No, some problem is there. I think I'm unable to do that.
Oh, okay.
Include computer sound नहीं हो रहा है क्या? Okay, okay. I think there's some problem. I am unable to share. Otherwise, I
Sure,
was
ma'am.
having a few patients video. Okay. Okay, actually these videos from the our patients group stressing upon plasma collection so that they are able to get their IVIG therapy. That's an ongoing therapy, and for the most common forms of PID, it is this is the treatment. And IPSPI is the only national organization for PID, and our organization IPOPI also they had a in between they had a relay for this, and we all had participated, stressing upon plasma collection, more and more plasma collection, so that all the patients can get their IVIG dose regularly. You can like us on Facebook. We do have a Facebook page, IPSPI Indian Patient Society for Primary Immunodeficiency. You can follow us on Instagram, and our website is www.ipspiindia.org. Thank you so much. There is a lot to be done, and IPSPI has strived forward in spite of so many challenges. The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep, and miles to go before I sleep. These are some of the lines of Robert Frost which I can remember here. So IPSPI was started somewhere in 2004, and now it is 2021. We faced so many hardships, but still we continue to strive forward, and in spite of the challenges, we are striving forward to meet the goals. Thank you so much.
Thank you, Ruby ma'am, for taking us through in detail over all the efforts put in by IPSPI. We sincerely wish you and your organization all the best for all future efforts to increase awareness for PID in India. We have received a couple of questions from the audience. I would like to address them. Like, I would like to read the questions, and then I invite Dr. Stalin, Dr. Sagar, and to address the questions. The first question is one of the parent is concerned about the COVID susceptibility of children post BMT, especially the SCID SCID kids, who suffer that condition. Dr. Stalin, would you want to take the question, sir?
Hello, can you hear me?
Yes, sir, we can hear you, sir.
Yeah, thank you very much for the question. So luckily or unluckily, we actually ideally don't want our children to get COVID immediately post-transplant, because especially in the first 3 months or 100 days post-transplant, their immune system is really down. So that is the time where if somebody gets a COVID, it is possible that the COVID is going to be quite severe. And so that is the one situation. But on the other hand, if somebody gets COVID little late in the transplant, after transplant, then I think they may not, the evidence is not that they are suffering extremely badly because of COVID. So it is, though we have to take all the precautions that is possible, but if somebody gets a COVID, I wouldn't really it can affect like everybody else, and unless you get it in the very early on after the transplant. And and as you know, some of the damage in COVID is due to the immune system as such. So it's so far the studies have not really shown that they are extremely at high risk of dying if they get COVID immediately after the transplant. So we have to take all the precautions, but at the same time, if it happens, we just have to see how things go.
Sure, sir. Thank you for that. Dr. Sagar, there's been one question from a patient regarding if there's an alternative treatment for PID.
Sorry, what is the question?
If there's an alternative treatment for PID, other than what you mentioned.
One needs to understand that PID, when I try to present, is not a single disease. We told that there are more than 400 different types of diseases. And so since these are a group of diseases, there is no one treatment that applies to all the patients. That is the very first thing that we need to understand. A group of patients have very low immunoglobulins, and these children must be given immunoglobulin infusions every month for life. Then there are another subgroup of patients who are quite severe immune deficiencies, which Dr. Stalin presented, and they need bone marrow transplants. And then there are milder forms of primary immune deficiencies, for example, IgA deficiency, wherein just antibiotic prophylaxis and no major intervention can help these patients. So there is nothing called alternative treatment. There are different forms of treatment for different kinds of PID.
Sure, sir. I hope that has addressed the question. And one another question is, like, if, for example, God forbid, any of the PID patients happens to have COVID. So can you just reiterate the approach to how to treat them?
See, the treatment for COVID in a child with immunodeficiency compared to any other child would essentially remain the same. If unfortunately some child with an immune deficiency catches up with COVID, the very first thing they should do these days is at least to get a video consultation done with their pediatrician or with an expert in the field. Number one. Number two, definitely they should keep a check on their fever status, and also they should regularly monitor their saturations, which all of us now know how to do it at home. And if the fever persists for more than 3 to 4 days, that is the time they should definitely consult a doctor, and there may be a need to do more investigations. Most of these children, even with immune deficiency, will have a milder disease and they may not have major challenges. But unlike other people, these children are definitely at higher risk of developing problems, and that is why being closely observed by a doctor would be advised. The treatment will only depend on how severe is the problem. If it is a mild problem, they are not treated in any different way compared to other children.
Sure, sir. I encourage the audience, if anyone has any questions, please feel free to unmute yourself and then ask the questions directly. Okay, it seems like there are no questions. I would now welcome Dr. Ranjit S. Ajmani, sir, PlasmaGen BioSciences Chief Executive Officer. A brief on Dr. Ajmani, sir. He holds a doctorate in biomedical engineering from IIT Mumbai and has later continued his research at NIH USA. Currently, in addition to being the CEO of PlasmaGen, he passionately finds time to continue to work as an advisor to the Government of India on various transfusion medicine and plasma product related issues. He has been an instrumental figure and has passionately contributed to the improvement of field of plasma protein therapy in India. We welcome him to share his thoughts. Over to you, Ranjit, sir.
Hi, Shivantika. Thank you very much. And I would like to thank Dr. Stalin and Dr. Bhattad. Uh, I'm seeing them after a long time, maybe a couple of years back. We met at a CME, and now good to see you all. And thank you very much for taking out time on the weekend and sharing your thoughts and helping the entire PlasmaGen team to make this discussion more full and more productive. And unfortunately, we all are tied up in a situation where we can't meet face to face, which would have been the best scenario. But I'm sure time would come where we all would meet and do something more worthwhile and more productive. So thank you very much, Dr. Bhattad, Dr. Stalin, and also Mrs. Ruby Chawla. For a long time associate, I've been to Bhubaneswar many times to give my talks at CMEs and also in Delhi. So thank you very much. And as I just want to update everyone that our plant construction is on, and hopefully we will be able to produce IVIG in Bangalore in time to come. And we would be very happy to take you to the plant once the situation is right and you will be able to see that. And if we can do for the society, for the patients, we will be more than happy to do it to best of our abilities we can do. So please do let us know if anything we can do. That's all I can say. Thank you very much and taking out time. Thank you.
Thank you, sir.
Thank you.
Thank you.
Very good evening to all in the audience. On behalf of the entire PlasmaGen BioSciences family, I cordially thank you all to have come and spent your evening with us together to commemorate the Global PID Week celebrated worldwide. Words cannot express the level of patience and support exhibited by these dignitaries and that we've all heard right now. On behalf of PlasmaGen BioSciences, many thanks, Dr. Sagar Bhattad, Dr. Stalin Ramprakash, Mrs. Ruby Chawla. Ma'am, PlasmaGen BioSciences is truly humbled to have put together this program under your kind and patient guidance. Through this program, we have taken our awareness creation efforts digital, and we thank everyone who has taken time to add some clarity towards the curiosity in the current scenario. For those who have joined us late into the session or might have missed out a few crucial minutes, please be assured we'll be sharing the link to the session at the earliest with you via email. We also have your contact details. We eagerly look forward to connecting with you soon, especially tomorrow. We have another session. We look forward to meeting you again. Thank you once again from all of us at PlasmaGen BioSciences.